afternoon. I am Kerstin Cornell, a licensed marriage and family therapist and a doctoral candidate at Baylor University. Today, I present my dissertation defense in fulfillment of the requirements for a doctoral degree in learning and organizational change. My presentation will outline the purpose of my study, the methodology I employed, the findings I obtained, and the implications for both clinical practice and future research. I would like to begin by thanking my committee members for their time, guidance, and support throughout this process. My dissertation title is, Why Now? A quantitative analysis of barriers influencing a delay in treatment-seeking behavior for adults with OCD. Before we address my problem statement, I would like to first outline how I define OCD. OCD has four interconnected parts: the obsession, a thought, urge, or image, which causes marked distress leading to attempts to ignore or suppress these thoughts, urges, or images through compulsions. Relief is experienced temporarily, and then the cycle begins again. OCD presents in various subtypes, which are aligned with the content of the obsessions. The content often reflects fear of violating cultural, religious, and societal values. Culture in this study includes gender, age, country of origin, race and ethnicity, religious denomination, among others. So why is this important? Right? 2.3% of the U.S. population has been diagnosed with OCD, and 3% of the global population. The average age of onset for OCD is 19.5 years. Biological males experience OCD typically earlier than biological females, though females and unmarried individuals exhibit higher rates of symptom severity. Socially, OCD can lead to isolation and strained relationships with family, friends, and colleagues, as the disorder's symptoms often disrupt daily interactions and communication. Economically, OCD contributes to financial burdens through healthcare costs, reduced productivity, unemployment, and family financial strain. Physically, chronic anxiety and repetitive behaviors associated with OCD can result in stress-related health issues, repetitive strain injuries, and co-occurring immune-related disorders. OCD is a treatable condition. However, many barriers exist to accessing timely and effective treatment. Personal barriers include shame and stigma, fear of the content of the obsessions, feeling afraid of being labeled as crazy, and many more. Systemic barriers include a lack of providers who are knowledgeable about evidence-based treatment for OCD, who also accept insurance, the cost of treatment, historical misdiagnosis, and a history of the way a person was treated in the past by mental health professionals or medical providers. Systemic barriers can also include history of racial inequities and institutional racism. Societal barriers include misinformation about treatment, conflicting cultural norms, and social pressure. A large portion of individuals who experience OCD do not receive timely treatment to prevent long-term impairment. Individuals with untreated OCD face significantly worse outcomes, including increased comorbidities, functional impairment, and an elevated risk of suicide. There is a gap that averages 17 years between symptom onset and treatment. The treatment gap reflects a disconnect between the availability of effective interventions and the barriers that prevent individuals from accessing them. The purpose of this study is to explore the personal, systemic, and structural barriers to delayed treatment-seeking behavior in adults with OCD. The findings of this study aimed to enhance support systems and improve service access for individuals navigating the complexity of treatment seeking for OCD, ultimately identifying key barriers through a behavioral lens, contributing to more informed decision-making among clinicians, researchers, and health system leaders. I have 4 research questions as outlined here. I will review each research question again prior to each research question's subsequent results section. I use the Combi framework by Michie and Associates to conceptualize this research. C stands for capability. This refers to the knowledge barriers to treatment. O stands for opportunity. This refers to structural barriers to treatment. M stands for motivation, and this stands for attitude and stigma barriers to treatment. And B stands for behavior, in this case, treatment seeking. I utilize a quantitative cross-sectional survey design using a demographic survey and the barriers to access care evaluation by Clement and Associates. I used a combination of non-probability, purposive, and snowball sampling. I utilized resources including the International OCD Foundation website, peer networking with other therapists, and social media blasts. Participants were all over the age of 18 and could provide their own consent to research. Data was collected through a Qualtrics link. Using Cresswell and Cresswell's data analysis spiral as a guide, I ran descriptive statistics, a moods median for research question 1, a logistical regression for research question 2, a point-biserial correlation for research question 3, and a Mann-Whitney U for research question 4. Data cleaning yielded 104 participants ages 18 to 67 and recorded a BACE score of 1.78. Among gender groups, cisgender women reported the highest perceived barriers, followed by cisgender men, and the participants identifying with another gender. Non-white participants reported higher perceived barriers than white participants. Treatment history also revealed differences. Participants who entered treatment within 1 year reported lower perceived barriers compared to those who delayed treatment for more than a year. Participants in the 50,000 to 149,999 thousand income bracket formed the largest group and recorded a mean BACE score of 1.72. Those earning less than 49,000 reported the highest perceived barriers, while participants with income of 150,000 or more reported the lowest. Participants who identified as religious or spiritual also reported higher perceived barriers compared to those who did not. In terms of living environment, participants in urban areas reported higher perceived barriers than those in rural areas, surprisingly. Research question 1. Reminder. Is there a statistically significant difference in BACE scores between individuals who initiate OCD treatment within 1 year of diagnosis and those who delay treatment for more than 1 year? Participants who started treatment within a year reported slightly lower barrier scores than those who delayed more than a year, but the difference was not statistically significant. However, the sample sizes were not equal and could have contributed to the lack of statistical significance. This means people who sought treatment within a year of diagnosis had lower BACE scores, but because the results were not statistically significant, the difference could have happened by chance. Logistic regression analysis showed that the combined set of barriers significantly predicted whether participants initiated treatment within 1 year or delayed treatment, explaining 36.7% of the variance and correctly classified 94.9% of cases. Among the predictors, stigma and structural barriers were significant, while attitude and knowledge were not. This means stigma and structural barriers were important predictors in treatment delay. Time from diagnosis to treatment showed a significant positive correlation with knowledge barriers, but not with stigma, attitude, or structural barriers. These results suggest that greater knowledge barriers were associated with longer delays in treatment initiation, while other barrier types were unrelated to treatment timing. This means people who waited longer to begin treatment were more likely to report knowledge barriers, but waiting time was not linked to stigma, attitudes, or structural issues. Non-white participants reported higher mean and median BACE scores than white participants. However, the Mann-Whitney U test showed that the difference was not statistically significant, indicating that race was not a significant predictor of perceived treatment barriers in this sample. Non-white participants reported more barriers than white participants, but the difference was not strong enough to rule out chance. This could be due to unequal sample sizes between groups. Taking it back to that Cone-B framework, I identified structural, stigma, and knowledge barriers contributing to treatment seeking. This means that capability, opportunity, and motivation all played a role in treatment seeking behavior. This slide shows how my 4 research questions connected to existing studies. For each research question, you can see which prior research supports my findings and which studies found something different. This highlights both where my results strengthen the current evidence and where it raises new questions. The study highlights that individuals with OCD often face delays in treatment due to knowledge, stigma, and structural barriers, which influence timely treatment. Recommendations include empowering individuals through access to evidence-based resources and peer support communities. Healthcare providers can address the stigma surrounding mental health, offer symptom recognition resources early, and create inclusive environments with greater treatment accessibility through solutions like telehealth. I urge policymakers to reduce systemic inequities through insurance reform, infrastructure investment, and national licensure systems. Researchers are called to include more diverse participants and employ longitudinal and/or mixed method approaches to better capture evolving barriers and evaluate interventions that improve timely treatment access. This slide shows how I'll share the results with different audiences: individuals with OCD, providers, policymakers, and researchers, using conferences, journals, and professional networks tailored to each group. Here are my references. Finally, I want to thank my committee, my colleagues who supported me on this quantitative side, my cohort for their encouragement, and of course my family and friends for their constant support.